up pretty much intrinsic versus extrinsic causes. And we just have kind of a list of the different kinds, because it
Sure.
seemed like you were saying kind of early on, that's one of the things you have to kind of determine between, is it an infection? Is it something within the joint? It could be something totally outside of the knee causing this pain. So we just have a couple things listed, but what are some of the, I guess, more common things that you see outside of infection? Of course, I know we said
Sure.
osteolysis and aseptic loosening for the later stages when they come back with pain later on. But other than that, what are some of the things that you sometimes see for knee pain?
So there's real world and there's the test. So on the
Yeah.
test, the most common things you see are infection, osteolysis, loosening, patellar maltracking, and then they may show you some flexion instability with the knee partially dislocated or something like that. In real life, in real clinic, that's actually not the most common thing you see for painful total knee. The most common things you see are you see a lot of extrinsic causes like IT band syndrome, patellar tendonitis, pes bursitis, things that get better with PT. You see a lot of hip arthritis. I see, so most of the things you see are not really mechanical, that can be fixed with a revision, which is, it can be actually frustrating for patients because they want there to be something wrong with the knee so that you as a surgeon can say, oh, I know what I can fix and I can make it better. Not every patient really wants to hear that, oh, it's a physical therapy thing and you need 6 to 8 weeks of physical therapy to get better. Like,
Right.
or that I don't know what's going on. So I think that these are all, these are things that you have to be careful about and be a little bit of an investigator with regard to your physical exam. Back to the previous slide real quick. I want to make sure I didn't miss any of those. Yeah, we talked about instability, arthrofibrosis. That's just a pain. That's more painful for surgeons. It's painful for patients too, but those cases they're tough cases. I will give people one revision for arthrofibrosis, but some people just get stiff. And you can do everything mechanically you can, and they're just going to be stiff, and those are difficult discussions to have. Implant impingement. Yeah, I mean, you can kind of see that sometimes. It's pretty rare, I think. Extensor mechanism disorders, that's a catastrophic complication. It's usually not a cause of pain unless someone has sometimes what you can see is, if you make your arthrotomy too close to the patella, you don't have a good soft tissue sleeve, that arthrotomy can rupture. And that functions a little bit like an extensor mechanism disruption where the patient is unable to extend the knee. They can't do a straight leg raise, but if you actually hold the patella reduced over the femur, they can actually do a straight leg raise and they can extend their knee. But when you take your hand away, the patella dislocates. So sometimes patellar instability is due to implant malrotation. Sometimes it's due to frank failure of the arthrotomy. So that's something to kind of look for. Extensor mechanism allograft. This is a topic that is a little bit of a hot topic now. I think I might be on the older school side of things, which is weird for me, but it's I have been more of an allograft type of person when it comes to these fixing these sorts of things. But I think more and more people are using mesh to augment their repair of extensor mechanism disruption.
Yeah, no, one of our attendings does that.
Yeah, and it's a great thing because no matter what you use, whatever you use, you want to make sure you use it well, and you're basically creating more area for collagen and stronger suture grabbing, and you just want to make sure that whatever you do, it decreases, lengthening of your repair. So whatever you do, you want to do something. I think on the test, the answer is, and in real life, you shouldn't just do a direct repair. If you have a total knee in place and you have an extension mechanism disruption, you need to augment it with something, whether it's allograft or some sort of mesh. You can't just do a direct repair, it will fail.
Okay.
I think we have some more x-rays of some of the other intrinsic causes we could
close
up and touch about some of the things that we see.
Yeah, you sure hope that you see on the test, if they're asking flexion instability, that you see that X-ray on the left there. That's pretty much tells you what's going on. I think implant impingement here. This is very common. That person on the right side has, clearly has significant patella baja. And in flexion, what happens is that patellar button will impinge on the tibial polyethylene, or the patella will actually impinge on the native patella will impinge on the tibial polyethylene, and it's painful. That's a tough problem to address with knee replacement. There are things you can do with revision surgery to distalize the joint line, adding in some augments, taking a little deeper tibial cut. But you can only do so much, because you will run the risk of significant flexion extension mismatch. But clearly patellar impingement there on the right is what's likely going on.
And I think this is probably our last one that we're going to have for those who are watching on YouTube. But so this is so common on the test questions and things like that. Can you kind of see some of the signs that you're looking for when you're suspecting possible osteolysis, or and also loosening as well? You have one here that's loose also.
Yeah, let me see. I sort of lost our. Oh, there it is. Yeah. So asymmetrical. You see asymmetrical polyethylene wear. You see those large osteolytic lesions. You also see some radiolucency around the tibial component too. So those are all things that I would critically evaluate in that left X-ray. This is a great example that the middle X-ray. You really don't think the surgeon put that implant in like that. So if you got this X-ray, I would say, I would trust that most surgeons wouldn't put this implant in 15 to 20 degrees of varus. So that's probably loose. You don't necessarily have to have serial X-rays for that. You've clearly lost a lot of medial plateau here, and that implant is loose. So loosening on the femur is actually pretty hard to see. You've got to really look out for it. And this is a great example, the X-ray all the way to the right here. Anteriorly, you can see, anterior and posteriorly, you can see, sometimes people will explain that away and say, it's just some reactive bone overgrowth. But probably what's happened there is that tibia subsided a centimeter. So that when I see that in a painful total knee, I worry about subsidence. I don't automatically assume that it's overgrowth of bone. So people can get some reactive bone overgrowth in one area of the knee, but if you see it circumferentially, obviously that's cause for concern.
Not gonna lie, I didn't even catch that, and we put the slides up, we put those pictures up there. But that's a great finding right there. So you're saying Absolutely. that little bony overgrowth, that'll clue you in towards some subsidence of the tibia, right there where you're.
Well, when you think about it, especially if it's anterior, I mean, it's very hard to leave a lip of anterior bone when you're doing a knee replacement. You cut a flat tibia and you put it on top of a flat tibia. If all of a sudden that implant is now covered in bone anteriorly, it should clue you in that it could be a technical error. Maybe the implant was undersized. But regardless, I think that you've got to be concerned that implant is loose.
And the big things that clue you into it being osteolysis versus the aseptic loosening is you kind of look at the poly and see if there's any wear between that. Is that kind of correct?
Yeah. Yes, it doesn't take a lot of poly wear to have large osteolysis, large amounts of osteolysis. So I think, I have been surprised by osteolysis at revision. Luckily, it was not anything we couldn't manage with our normal revision techniques. But you can see significant osteolysis with almost an overlooked amount of polyethylene wear on the radiograph. So if you have a millimeter of difference, you may just quickly look at the X-rays and say, there's no significant poly wear. But that's why you really have to critically evaluate the X-rays and look for osteolytic lesions. And if you're careful, you'll see them. They're usually, if they're large enough to cause a problem for reconstruction, you should see them on X-ray. You don't necessarily have to get a CT scan on all these cases, but if you see a large lesion and you're concerned about fixation, I think that's an indication to get a CT scan just to evaluate what bone you have left for fixation if you're revising these components. So I think you can see significant osteolysis without significant polyethylene wear. I would think for testing purposes, they tend to show an X-ray kind of like the one all the way to the left, where there is, recognizable uneven polyethylene wear.
Absolutely. Yep. I'm glad you mentioned all of those because, early on, I would be looking at this and still not recognizing what's going on. So I think it
Me
was really
too.
good. Yeah, I mean, it's right in your face, but if you haven't seen it and it maybe had someone to kind of explain it to you, it'll miss you, even though it's hitting you right in the face.
Yeah, even those things like the varus and all that, like, this takes a little while, but no, I completely agree.
Absolutely. And so, Dr. Cody, thank you very much for this topic. I think this one is high yield for both clinical purposes and also test taking. So I feel like, a lot of different people in different levels of orthopedics will be able to appreciate this talk.